Hello, you're welcome to my platform. I am Dr. Sandra and I am a surgeon. I hope you become aware and sensitized about the different surgical conditions. Today's video is about an enterocutaneous fistula. An enterocutaneous fistula is an abnormal connection between a part of the intestine and the skin. This abnormal connection between a part of the intestine and the skin allows fecal matter to flow from the lumen of the intestine to the outside of the body through an opening in the skin. Majority of the time, that is 80% of the time, the enterocutaneous fistulas occur as a result of a complication of a surgery, but they can also occur as a result of trauma to the abdomen, patients that have cancer, especially cancer of the intestines, patients that have underwent radiotherapy, for example, due to cancer, and then patients that have inflammatory bowel disease, that is Crohn's disease, which is an irritation of the small intestine and the first part of the large intestine, and also ulcerative colitis, which is an inflammation of the large intestine. It can also occur due to ischemia. Ischemia means that there is a reduction in the blood flow to a given part of the body, and in our context, the intestines. And this can be because of a clot, or maybe there is a buildup of fats, a condition called atherosclerosis, and this can reduce the amount of blood that flows to the intestine, and so the patient can also get an enterocutaneous fistula. The signs and symptoms of the enterocutaneous fistulas include fevers, failure to pass stool and flutters, abdominal tenderness, that is when you touch the abdomen, there will be some pain emanating from the abdomen. There will also be pus discharging out of an opening on the skin on the abdomen. Eventually, there will also be fecal matter discharging from this opening on the skin of the abdomen. This opening on the skin of the abdomen can close off spontaneously. However, if there are some factors that prevent it from closing, it will not close completely, or it will take a long period of time to close. These factors don't only stop the fistula from closing, but they can also be responsible for the formation of this fistula. These factors are best remembered using a sentence, the friends of the fistula, or an acronym, a short form, FRIENDS. F stands for foreign body. If there is a foreign body in the area of the fistula, it will not close off. R stands for radiation. If the patient received radiation in the past or has ongoing radiation therapy, for example, if they have cancer of the intestines. I stands for inflammation, that is irritation or infection. E stands for epithelialization. Epithelialization is when the cells of the skin migrate and line that tract that connects the lumen of the intestine to the skin. So if these cells of the skin migrate and line that tract, it will remain open and the fistula will not close off. N stands for neoplasm. Neoplasm simply means cancer. If there is cancer going on, or if there was cancer that caused this fistula, the fistula will not close off. And this stands for distal obstruction. Distal obstruction simply means that there is something in the intestines that is obstructing the lumen of the intestine, especially in the portion of the intestine that is closer to the anal opening. Therefore, in all patients that have enterocutaneous fistulas, we have to look for these factors. The patients will be predisposed to complications. These complications include dehydration. Dehydration occurs when the amount of fluid that is being lost through the fistula is more than the amount that the patient takes in, and so the body will not have enough water to carry out its functions. So the patient loses a lot of water. That is dehydration. The patient will also have another complication called electrolyte imbalance. Electrolyte imbalance is when the minerals within the patient's body that are responsible for the communication between cells are reduced or increased in amount. And this is usually as a result of loss of these electrolytes through the fistula or as a result of dehydration, loss of fluids. The patient is also predisposed to getting malnutrition. Malnutrition usually occurs because the food that the patient eats passes through the fistula before the nutrients have been absorbed by the body. The other complication is intra-abdominal abscesses, that is pus formation in the abdominal cavity. This is usually as a result of leakage of the fecal matter into the abdominal cavity. So the patient will have pus formation in the abdominal cavity. When the fecal matter leaks into the abdominal cavity and we get pus formation in the abdominal cavity, the body will try to eliminate the infection that is going on in the abdominal cavity. And in the process, the body's cells are going to produce some chemicals, and these chemicals can cause a reduction in the blood pressures, and so the amount of blood and oxygen that reaches the vital organs of the body, for example the brain, the kidneys, the heart, will also reduce, and these organs will shut down and the patients can easily lose their lives. In fact, 2/3 of the patients that have enterocutaneous fistulas die from sepsis, especially sepsis arising from intra-abdominal abscesses, that is pus formation in the abdominal cavity. The investigations that we carry out in the enterocutaneous fistulas include a complete blood count, and this can help us know if the white blood cells are elevated, as this can point to a possibility of sepsis. We can also do serum electrolytes, looking out for any imbalances in the electrolytes. We can as well carry out some imaging modalities that can help us assess the anatomy of the fistula. For example, we can do an ultrasound scan, we can do a barium swallow and follow through. We can also do a fistulogram as well as a CT with oral contrast. The CT with oral contrast is the best imaging modality because it can help us identify the location of the fistula, especially the opening on the intestine. It can also help us know if we have any leakage of fecal matter into the abdominal cavity. Also, if we have pus formation in the abdominal cavity, as well as presence of distal obstruction in the intestine. When it comes to the treatment of the enterocutaneous fistulas, we have two options. We have the medical management and the surgical management. And majority of the time, we usually choose medical management first before we can attempt surgical management, except in a few cases. But before we can undertake any of the treatment modalities, we have to first stabilize the patients, because majority of the time they have complications going on. For example, dehydration, electrolyte imbalances, sepsis and malnutrition. So we must intervene. For example, patients that have dehydration, we have to give IV fluids. We can also give oral fluids. Patients that have the electrolyte imbalances, we must rectify the imbalances. And this is dependent on which electrolyte is deranged. Patients that have sepsis, we have to identify the source of the sepsis. And majority of the time, it is usually an intra-abdominal abscess, that is pus collection in the abdominal cavity. And this has to be drained. Remember that sepsis is responsible for 2/3 of the deaths of these patients. And so we have to be on the lookout for the signs of sepsis in these patients. Malnutrition also has to be managed, especially for patients that have high output fistulas, that is, they produce fecal matter of more than 500 mils in a day. So such patients might benefit from total parenteral nutrition, where the nutrients are given through the veins. But for patients that have low output fistulas, that is, the effluent, the fecal matter coming out of the fistula is less than 200 mils, we can always give the feeds via mouth, and we have to make sure that the food that we give them is balanced. It has to be a balanced diet. It has to contain vitamins, proteins, fats, carbohydrates, such that the patients can be well nourished. Remember when I talked about we can choose medical management versus surgical management? For example, if we have chosen medical management, the goal of medical management is to make sure that we reduce the output of the fistula, we reduce the amount of fecal matter or the fluids and feeds that are lost through the fistula. And then the other goal is to make sure that we increase the chances of this fistula to heal spontaneously. And because 80 to 90% of these patients can heal with medical management, we usually don't rush to do surgery. So we have to make sure that we start with medical management before we can attempt surgical management, because sometimes surgical management can be very risky, especially if the patient has had a previous surgery. We can easily cause damage to the intestines as we are trying to operate these patients, because majority of the time the intestines are stuck together. They have what we call adhesions. So we don't gravitate towards surgical management. We always choose medical management, and if medical management fails, that is when we can now attempt surgical management, because we have no other options left.
The other reason why we choose medical management over surgical management is because surgical management is associated with high recurrences, meaning that these patients can easily get other fistulas in the future. So it is very important that we start with medical management versus surgical management, because surgical management has very many complications. When we do medical management, these fistulas can even close within 5 weeks, but we can proceed and attempt medical management for about 3 months. Because medical management has less complications, even the death rates in these patients is lower when we use medical management versus surgical management. So to emphasize, let us always start with medical management before we go to surgical management, unless if maybe it is a high output fistula, or if the fistula is a little bit higher in the intestines, maybe in the jejunum. That is when maybe we can choose surgical management over medical management. During medical management, we have to evaluate for the factors that are responsible for preventing spontaneous closure of the fistula. The ones that I talked about earlier, the friends of the fistula, that is foreign body, radiation, inflammation or infection, epithelialization, neoplasm, and distal obstruction. So we have to look out for those factors, and the ones that are modifiable, that is the ones that we can control, the ones we have control over, we can always manage those ones such that we can increase the chances of the fistula closing spontaneously. Still, in the medical management, we also have to carry out some interventions that reduce the output of the fistula. Because remember, the higher the output of the fistula, the lower the chances of the fistula closing spontaneously. So we have to make sure that we do some interventions that are going to reduce the output of the fistula. In order to reduce the output of the fistula, we have to give some medications. For example, we can give the proton pump inhibitors. We can also give the H2 antagonists. We can give antidiarrheal drugs like loperamide. We can also give octreotide. These drugs are going to reduce the amount of effluent, the amount of fecal matter that is lost through the fistula. And this can increase the chances of this fistula closing spontaneously. The second option in the treatment of the enterocutaneous fistula is surgical management. And this is usually done after failure of the medical management. For example, the patient has been treated for about 3 months and the fistula is not closing off. We can then go to surgical management. But surgical management also works better if we have tried medical management for some time. The other time we can use surgical management is when we have high output fistulas. High output fistulas are the ones that produce the effluent, the fecal matter, of more than 500 mL, half a liter in a day. And those patients that have the fistula affecting the upper parts of the intestines, for example, the jejunum, because it means that when the patient feeds, the food gets out of the fistula very fast before it can reach the lower part of the intestine for the nutrients to be absorbed by the body. So that means that such a patient is at risk of developing complications, and so they are best managed surgically. During surgery, we have to make sure that we don't cause unintentional damage to the intestines, because this can predispose the patients to recurrences, that is, they might get other fistulas in the future. The surgery that we do is excision of the fistula tract plus resection and anastomosis plus closure of the fascia where the fistula tract was passing. Excision of the fistula tract means that we cut away that tunnel that was connecting the intestine to the skin, and then we do resection and anastomosis. Resection simply means that we cut away that portion of the intestine that has the fistula, the opening, the hole, and then we do anastomosis. Anastomosis means that we join the two ends of the intestines to make sure that we have continuity of the intestine, because we cut away the intervening portion of the intestine that had the opening. And then we close the fascia where the fistula tract was passing. The fascia is just one of the layers of the abdominal wall, so we just close the fascia, and then this can help prevent another fistula from developing. The take-home message is caring for patients that have enterocutaneous fistulas requires a significant amount of patience on the side of the healthcare professionals, the relatives of the patients, and the patients themselves. This allows the patients to benefit from the non-operative management, the medical management, that actually sets them up for better outcomes. Because remember, surgery is risky and it has poor outcomes. However, good discernment and judgment is required for the health workers to decide on whether to take on the surgical management versus the medical management, because there are so many factors that interplay on whether we should start with medical management or do surgery right away. For example, patients that have high output fistulas and also patients that have proximal fistulas that are high up in the intestines, for example in the jejunum. These patients are also predisposed to getting complications, for example malnutrition. So it is very important, especially for the attendants of the patients, the caregivers of the patients, to provide these patients with foods containing all the necessary nutrients, for example, proteins, carbohydrates, fats, vitamins, minerals, such that these patients don't succumb to malnutrition. And for the health workers, please be on the lookout for signs of sepsis, signs of dehydration, and signs of electrolyte imbalances, because these can also kill these patients. Yes, that is what I had for you. Thank you so much for listening to me. Please share my videos and also subscribe. See you in my next video. Bye.